Assalamu alaikum. How the major and the minor salivary glands are precisely regulated to produce the right quantity and quality of saliva for oral protection, mastication, taste, deglutition, and speech. When the salivary glands or its regulatory mechanisms dysfunction, we get manifestations of several diseases and disorders. Hyposalivation is by far the commonest secretory disorder. Then we get things like xerostomia, oral dryness, and we get oral mucosal atrophy and ulceration, and it would be difficult to chew food and swallow it, and you may get dental caries or oral infections. Hypersalivation is not so common, but when it happens, you will get drooling, and if it is posterior hypersalivation, you may get aspiration. Other secretory functional disorders of the salivary glands could present like salidinosis or sialosis when there is a disturbance in the secretory and the synthesis mechanisms of the protein granules in the major salivary glands, particularly the parotid, producing parotomegaly and several other disorders. Saliva have various functions, including the lubrication, lavage, and cleansing of the oral cavity by virtue of its protein-rich glycoproteins, mucins, and the water content. It also has an antimicrobial effect. This helps in controlling any infections in the oral cavity by virtue of different lysozymes and IgA secretory pieces. It maintains oral mucosal integrity by mucins and electrolytes and water. It also can make the bolus formation of food much easier by providing water and different other ingredients, and facilitate the taste perception of food when it is in a liquid form. It helps with mastication and speech and in digestion by virtue of the amylase content, which helps in the digestion of starch. Also, it contains lipase, ribonuclease, and proteases, which are also helpful in digestion of various other classes of food. It maintains a fairly steady pH of the oral cavity by virtue of its buffering regulatory mechanisms. It contains bicarbonate and other buffers, and that helps in maintaining the pH in the oral cavity of the saliva between 6.5 and 7.4, and it protects against the acidic challenges from bacterial carcinogenic pathogens. It helps in remineralization because it provides several minerals in its water content, including bicarbonate, phosphate, ions, proteins, and calcium. These are some of the salivary functions. It is also essential in the protection of the oral cavity from various infections and helping with the healing of the oral cavity, which is constantly irritated by thermal or mechanical or even chemical irritants. The factors in the saliva that helps in promoting wound healing in the oral cavity include the epidermal growth factor, the fibroblast growth factor, insulin-like growth factor, nerve growth factor, and transformine growth factor alpha and beta. A healthy adult will produce anything between 0.5 and 1.5 liters of saliva per day. 90% of this amount would come from the major salivary glands. The basal salivary flow rate is somewhere between 0.3 and 0.4 milliliters per minute, but on stimulating the salivary flow could increase 5 times. Saliva is quite rich in potassium. It has 7 times the concentration of potassium in the plasma, but equally good, it's very low in sodium with only 1/10 the concentration of plasma. It's also low in other things like calcium, phosphorus, chloride, thiocyanate, and urea. The resting pH of saliva is between 6.5 and 7.4. A normal adult would usually swallow approximately once every minute to clear any residual saliva from the oral cavity. The number per day could be somewhere between 600 and 900 swallows in a day. The basic salivary secretory unit is formed of an acinus, in which there are cells that secretes the initial saliva, surrounded by myoepithelial cells that contract to push the saliva into the duct system. There may be 3 types of cells lining the acinus, and there are 3 types of cells lining the ductal system that ultimately connect to drain into a common drainage into the oral cavity. For the acini, the 3 types of cells are either the serous acinus, which is spherical cells full of zymogen granules. These are protein-rich granules, or mucinous cells. Here the cells are more tubular and are full of granules of mucin, or it can be a mixture of the two with some serous acini and some mucinous acini. The relative abundance of the serous or the mucinous acini in a particular gland would dictate what the consistency and the composition of the saliva secreted by that gland. In the acinus, all the fluid movement from the bloodstream to the saliva occurs from the acinar cells. All the water, most of the proteins, and most of the electrolytes would happen through the acinar cells. The initial saliva would be isotonic and would drain into the duct system, where it is going to be progressively hypotonic as it passes through the 3 types of the ductal cells by the absorption of sodium and chloride and the secretion of potassium and bicarbonate. You could see here the 2 main types of acinar cells. The more bluish type here stained with hematoxin and eosine are the serous acinus cells. The clearer type are the mucinous, because the mucin would be dissolved by the hematoxin and eosine during preparation. And the relative amount of serous or mucinous in different glands would vary. For example, in the parotid, it would be mostly serous, and this will produce a thin and watery saliva. In the sublingual gland, it will be mostly mucinous, giving rise to thick and mucin-rich saliva. Submandibular gland would be somewhere in between. The minor salivary glands also are mostly mucinous in type. To push the initial saliva from the acinus into the ductal system, we need the myoepithelial cells. These are the cells with long pseudopodia that we can see surrounding the acinus. They are epithelial cells with contractile properties. They can squeeze the initial saliva from the acinus into the duct system. They can also surround the intercalated part of the duct system, as you can see. Its function is essential to propel the formed initial saliva from the acinus into the ductal system. And if this cell, the myoepithelial cell, is defective, you could have accumulation of saliva inside the acinus and various disorders. The initial fluid, the initial saliva secreted by the acini, are pushed into the ductal system. You have 3 types of duct cells, 3 types of duct systems: the intercalated duct system initially, followed by the striated ducts with this basal striation in the basal part full of mitochondria, and then the final secretory duct at the end. As the fluid passes through the duct system, it becomes progressively less isotonic. It becomes eventually hypotonic. Most of the sodium and the chloride are absorbed in the ducts, and more potassium and bicarbonate are added to the saliva, and some protein from the intercalated part of the duct system. So the final saliva secreted from the excretory duct would be different from the isotonic saliva secreted in the acini. In the basal saliva, without stimulation, without the resting saliva, would be hypotonic, slightly alkaline due to the bicarbonate in the saliva, and will be rich in protein and the potassium secreted through the duct system. When the salivary glands are stimulated, the flow of the saliva is more rapid, and there will be less time for the ductal cells to absorb the sodium and the chloride or excrete potassium and bicarbonate. Therefore, the fluid would have higher concentration of sodium and chloride and a lower concentration of potassium and also bicarbonate, and it will become less hypotonic than the resting or the basal saliva. The first part of the 3 parts of the duct system is formed of the intercalated duct. These are the short ducts leading directly from the asinus into the remaining part of the duct system. So this is the initial part of the duct system, still surrounded by the myoepithelial cells in order to squeeze the initial saliva into the remaining part of the duct system. The intercalated ducts can also secrete some proteins, mainly lysozymes and lactoferrin, and can also absorb chloride and secrete bicarbonate into the isotonic fluid coming from the asinus cell, and it pours into the striated part of the duct system. The saliva would then move from the intercalated part of the salivary unit to the striated part of the duct. The striated part of the duct system has cells with extensive stria at the basal and the basolateral parts of it, full of mitochondria. They are quite active in absorbing sodium and chloride and secreting potassium and bicarbonate into the saliva. The longer the striated duct, the more alteration to the initial saliva would happen. Also, the faster the flow of the saliva, the more alteration of the initial saliva would happen. In glands where it is mostly mucinous, like for example the sublingual glands or the minor salivary glands, very little alteration to the initial saliva would happen in the striated duct because they are quite short and the mucinous types of salivary glands. On the other hand, in the serous glands like the parotid, there will be long and well-developed striated ducts, and quite a significant alteration of the saliva would happen here, giving rise to a very hypotonic saliva at the exit from the striated duct segment. And finally, all the collected saliva from different parts of the salivary units would drain into an excretory duct. No much modification to the saliva would happen here. It's just an exit path from the salivary secretory unit to the oral cavity with no or very little modification to the salivary composition. In addition to the salivary secretory units, the salivary glands also contain other things, like they are very rich in lymphocytes and plasma cells responsible for the production of IgA, for example. In the salivary secretory unit, it's only the acinar cells that are permeable to water. The duct cells are not permeable to water. All the fluid transport would happen in the acinar and the acinus, and the fluid would then passes through the duct system. No fluid absorption or secretion would happen here, only modification of the initial saliva by absorbing of sodium and chloride and secretion of potassium and bicarbonate, and addition of little protein in the intercalated part of the duct system. In addition to the 3 pairs of the major salivary glands, there may be around 600 to 1,000 minor salivary glands in the oral cavity and also in the oropharynx. The minor salivary glands produce saliva independent of stimulation. They produce between 7 and 8% of the total salivary output, mostly in the resting or the basal type of saliva secretion, not the stimulatory part. The saliva secreted from the minor salivary glands are rich in mucin because most of these minor salivary glands are mucinous. The green tagged ones are mucinous. They are almost all of mucinous type, with an exception of a small part around the circumvallate papillae of the tongue, which and here the minor salivary glands are of the serous type, and small part at the tip of the tongue and the free edge of the upper and the lower lips, where the minor salivary glands are of the mixed type, mucinous and serous. With no stimulation, the resting salivary flow rate, the basal salivary flow rate, is approximately 0.3 to 0.4 milliliter per minute. Now, on stimulation, this would increase on chewing or on thinking about food, or when stimulated by the smell or the taste of food. This would increase 5 times to 1.5 or 2 milliliters of saliva per minute. In the basal resting state, most of the saliva would come from the submandibular glands, which would contribute to just less than 70% of the output from the major salivary glands at rest. followed by the parotid gland with 26% and the sublingual gland with just 5%. However, on stimulation, the position of the parotid gland and the submandibular glands would reverse. The parotid gland would secrete most of the secretory of the stimulated secretory saliva, 69%. The submandibular gland would come next with 26%, followed by just 5% from the sublingual gland. Interestingly, the saliva and the salivary glands would change in response to dietary changes. It is known that the salivary amylase is present in low concentration in herbivorous animals, where their diet is rich in carbohydrates, but is almost absent in the saliva of the carnivorous animals with a protein-rich diet. The parotid glands could enlarge from excessive ingestion of starch, and it's known that individuals who are fed predominantly on carbohydrates can have increased salivary amylase activity as well as increase in size of the salivary glands. This would take maybe 2 months to modify the diet of high starch or carbohydrate content. It may take about 2 months to change the composition of the saliva and the size of the glands in response to the change of the diet. Experimentally, if you feed rats, for example, a diet that is quite rich in carbohydrates and is a bulky diet, they would have parotid glands enlargement and increased activity, again due to the acinar cell increase in size, but this would take few weeks. Saliva is secreted by the stimulation of both parts of the autonomic nervous system, the parasympathetic and the sympathetic stimulation. The coordination between the two systems to fine-tune the composition and the quantity of saliva is done centrally. It is the parasympathetic activity that produces most of the salivary stimulation. It is mostly tonic rather than intermittent. It's a tonic type of stimulation and produces most of the secretion. Interruption of the parasympathetic nerves to the major salivary glands by neurectomies would result in a gland atrophy. The extent of the vasodilatation of the blood supply to the salivary gland is also under the control of the parasympathetic activity, and this would influence the saliva production. Also, the parasympathetic activity is responsible for stimulating the contraction of the myoepithelial cells. On the other hand, the sympathetic stimulation tends to be intermittent rather than tonic. It deals primarily with the intracellular manufacturing and release of proteins such as zymogen granules. Interruption of the sympathetic supply to the nerves does not result in any significant histological changes in the salivary gland. The sympathetic stimulation can modulate the composition of the saliva by its influence on the exocytosis from some specific cells in the duct system. The sensory part of the reflexive salivary secretory arc would come through fibers of the trigeminal nerve. Receptors in the periodontal membrane would be mechanically stimulated during chewing, and there are also receptors in the oral cavity and the oropharynx that travels through the glossopharyngeal nerve. The trigeminal branches relays in the trigeminal nucleus, and the glossopharyngeal fibers would relay in the nucleus of tractus solitaris in the midbrain. Fibers from these sensory input would then affect the motor part of the reflex, the superior and the inferior salivary nuclei in the brain stem. These motor nuclei would also be influenced by descending fibers from the cerebral cortex, influenced by things like depression and anxiety, sleep, and other types of excitatory stimuli. From the superior salivary nuclei in the pons, fibers would travel with the facial nerve, the coda tympani, and then relay into the submandibular ganglia and ultimately supply the submandibular salivary gland and the sublingual salivary gland. The inferior salivary nuclei in the medulla would provide fibers traveling with the glossopharyngeal nerve, the tympanic branch of the glossopharyngeal nerve to the tympanic plexus. through this to the lesser superficial petrosal nerve after the tympanic plexus, into the optic ganglia, and ultimately to the parotid through the auriculotemporal nerve. These are the parasympathetic nerve supply of the three major salivary glands. The sympathetic supply comes from the superior cervical ganglia. The sympathetic fibers travel with the external carotid artery branches to reach the three pairs of the major salivary glands. A closer look at the parasympathetic supply of the parotid gland comes from the inferior salivary nuclei and the medulla, passes through the glossopharyngeal nerve, tympanic branch of the glossopharyngeal nerve, into the tympanic plexus in the middle ear, where it can be interrupted by tympanic neurectomy. Fibers from the tympanic plexus passes through the lesser petrosal nerve and passes through the skull base from the foramen ovale, and then relays into the optic ganglia, and then travels with fibers of the auriculotemporal nerve to the parotid gland. The sympathetic fibers come from the cervical 1 spinal segment, relays into the superior cervical sympathetic ganglia, travel with branches of the external carotid artery to the parotid gland. Some of the reflexive salivary secretion comes from the periodontal receptors. These receptors would be mechanically stimulated by the act of chewing, not necessarily food. Chewing on solid objects, like for example wax, could also trigger the reflex secretion. This reflexive secretion from the periodontal receptors is still maintained even in edentless patients. If they wear full dentures, they can still have the reflexive secretion of saliva when they are chewing, and the salivary output could increase by increasing the occlusal force by full restorative means in case of edentless patients. The parasympathetic stimulation would ultimately reach the salivary secretory unit, where it would release acetylcholine. This would interact with M3 receptors on the acinus cell and induce an influx of calcium, intracytoplasmic calcium influx, and this would promote fluid secretion from the acinus cell, all the fluid transport, plus also some electrolytes. The sympathetic stimulation would reach the acinar glands by the release of noradrenaline, and this would stimulate the beta-adrenergic receptors. And these beta-adrenergic receptors, on their turn, would stimulate the acinus cells to secrete protein. The physiological causes of salivation and even hypersalivation include the influence of cerebral cortex, and the autonomic neurogenic modulation over stimulation. They also include things like hormonal effects, particularly, for example, in pregnancy, metabolic effects, teething, pregnancy, nausea, can all produce saliva in excess amounts, ingestion of certain types of food, including sour or spicy food, and when a person smells or eats his favorite foods, and some pleasurable sensation or even anticipated pain could induce salivation or hypersalivation. In clinical practice, it is the reduced salivary flow that is much more common than excessive flow. And the most common cause for a reduced salivary flow are related to intake of medications with anticholinergic or with sympathomimetic effects. Other groups of medications like tricyclic antidepressants and phenothiazines, neuroleptics, are also among the most troublesome medications to reduce salivary flow, and things like anticholinergic, antimuscarinic effects, or ganglion blocking drugs can also reduce salivary glands flow. The medications that can induce xerostomia as their side effects generally falls into these two categories: medications with anticholinergic activities like atropine, for example, including hyoscine and ipratropium, tricyclic antidepressants, monoamine oxidase inhibitors, phenothiazines, and other medications including antihistamines, ganglion blockers, clonidine, and antiemetics. The other group are medications with sympathomimetic activities, like cold medications, decongestants containing epinephrine or phenylpropylamine, and medications used in asthma, like bronchodilators, isoprenaline, or appetite suppressants, particularly amphetamine and diethylpropine. In addition, some specific diseases could also influence the salivary flow, including, of course, all the diseases affecting the salivary glands themselves, but also a group of systemic conditions that affects the salivary flow without affecting the salivary glands directly, including things like depression and anxiety, dehydration, hemorrhage, diarrhea, chronic vomiting, and diabetes with polyuria. All these could reduce the salivary flow rate. And in addition to the effect of medications and some specific diseases on the salivary glands function, age can also induce some changes in the salivary glands histology. The secretory acinar cells may be replaced by fibrous or adipose tissue, and the acinar cells could lose up to 40% of its volume. This does not happen uniformly in affecting all the salivary tissue. It affects the submandibular glands much more than the parotid glands, for example. So it's mostly affecting the submandibular and the sublingual glands, to a lesser extent the parotid and the minor salivary glands. It does not only affect the volume of the saliva secreted, but also its composition, with a decreased sodium and increased potassium concentration of the saliva. And also with age, you would have increased levels of IgA and proline-rich proteins and antimicrobial proteins such as lactoferrin and lysozymes. The effect of age on the salivary gland functions affect both the stimulated and the unstimulated salivation. Both decrease with age, but it is the stimulatory part which is affected much more than the unstimulated part. The stimulated part of salivation induced by periodontal receptors is diminished, along with the lower chewing forces and the fewer natural teeth remaining. The resting saliva is reduced, even in healthy individuals, but it remains adequate enough to maintain oral mucosal moisture. In general, the number of chronic diseases and medications increase several folds with age. Many of these medications, more than 500 different drugs, could have the undesired side effect of hyposalivation and xerostomia. But in the absence of a major medical problem, or in the absence of frequent medication, the saliva composition in the elderly remains reasonably adequate, with diminished but still adequate reserve to maintain oral mucosal moisture. If this is lost, then there is either another condition, another chronic disease, or the medications, or a specific problem in the salivary glands. By this, we come to the end of this presentation on how saliva is produced and modulated. Assalamu alaikum.